Good morning or good afternoon, everyone, or good night. I'm not sure what time you're watching this. Today, I'll be presenting a quality improvement project focus on improvement. I'm sorry, focus on improving the timely removal of indwelling urinary catheters on our orthopedic surgical unit. Our goal is to reduce unnecessary catheter days and ultimately decrease the risk of catheter-associated urinary tract infections, or as many of you guys know them as CODIs. Identifying the problem. The problem we identify is that patients on the orthopedic surgical unit often retain their urinary catheter for longer than 24 hours, even when the criteria for removal are met. This delay increases the risk for catheter-associated urinary tract infections, or CODIs, and I will discuss on the next slide a little bit more about that removal criteria. A key fact to highlight is that the risk of bacteremia increases by about 3 to 5% for every catheter day. So minimizing unnecessary catheter time is essential for patient safety and for their outcomes. Cause and effect analysis. To understand what contributes to delayed catheter removal, we perform a cause and effect analysis across people, processes, equipment, materials, management, and the unit environment. Under people, we found issues such as inadequate training, low confidence in decision making, nurse deference to physician, communication gaps, and staffing limitations. Under nurse deference to physicians and communication gaps, many times the nurse might see an automatic order to remove the catheter on post of day one, or when the patient is mobilizing out of bed. However, there's a lot of these like kind of automatic orders that many times do not pertain to the patient. So it's been observed that sometimes, because it's so common for the orders not to really have a lot of weight, that they just kind of don't really like take them too seriously, and usually it has to wait until the doctor puts like a order within that nurse's shift for that person to kind of take it like, okay, this is up to date, or this is like a real to follow type of order. So that's where the difference to physicians and communications gaps is primarily found. Under process, unnecessary catheter use is common, often due to poor documentation or inconsistent use of removal protocols, like the Houdini, which is a protocol we use a lot. We may not always find it under that name, but it's like HOUDINI, and it's pretty much like an acronym that stands for a specific group of patients that usually are likely to require that catheter. So the H usually, or not usually, but it stands for hematuria, O for urinary obstruction, U for patients from urology, or if the catheter was placed from urology and it's needed for a specific reason, or if they have like a gyno like surgery and they are needing the catheter as well. The D is for dubitus, which is pretty much sacral ulcers, stages 3 or 4. And of course, you want to keep the that area clean and dry, and sometimes when incontinence is an issue, then they'll keep that catheter. The I is for INOs, so patients that are critically ill and they really need hourly INOs, then that's when the catheter will be appropriate. The N is for nursing, which just stands for patients needing um so like end of life care. I'm sorry, end of life care. And finally, the next I is for immobilization. Um, okay, next for equipment and materials. Some challenges include improper catheter sizes, which, the greater the catheter size, the likelihood for patients to have some trauma. Um, Limited availability of alternatives such as external catheters, um, and occasional use of open drainage systems. So we want to use a closed drainage systems over the open. Under management category, we have found gaps in interprofessional collaboration, training feedback, and protocol reinforcement was also noted. Finally, in the environment, there's a high patient turnover, complacency culture, and lack of real-time monitoring, which also it's contributing to the problem. And yeah, overall, these are the factors that are so far being the barriers in keeping those catheters for longer than needed. Defining a measurable SMART goal. So based on the problem analysis, we develop a SMART goal that incorporates nursing quality indicators. Our goal is to increase the percentage of indwelling urinary catheters removed within 24 hours postoperatively by 30% from baseline within 1 month after our interventions are completed. So as you can see, this goal is specific, measurable, achievable, relevant to the problem, and time bound. So it has all that criteria that's needed. And some of the ways that we're gonna measure the outcome will be by the average duration of the catheterization, the percentage of catheters removed in a timely manner, and the percentage of staff adherence to the removal protocols. Research interventions. So on the first article, it's pretty much a scoping review on multidisciplinary involvement in CAUTI prevention, which found that effective strategies include prevention bundles, routine training, daily catheter reviews, and a strong leadership engagement. They also found that team-based education, feedback, and use of catheter checklists also play a major role in reducing infection rates. The next one was pretty much a quality improvement study completed by a large healthcare system, which emphasized the importance of nurses' knowledge and practices. This study emphasized that communication, interdisciplinary collaboration, standardized protocols, real-time data monitoring, and ongoing education to significantly reduce CAUTI rates. Some of the key practices included promoting alternatives for indwelling catheters, using a standardized insertion checklist, and performing daily assessments to ensure timely removal. These are other of the interventions from different researches in articles, and also some more from those articles we just read. So implementation of best practices are usually alternatives to indwelling urinary catheters, the daily assessment for necessity of the indwelling urinary catheter, utilizing the Houdini, I'm not sure how to say that tool, which is the one that I talked to you guys about. Um, H, hematuria, O, obstruction, U, urology, D, debicutus or sacral wounds, stage 3 or 4, I for INOs, and for nursing or end of life care, and the last I is for immobilization. And the nurse-driven protocol for removal of indwelling urinary catheters when appropriate. So all these evidence best practices are actually already available to us in our units. However, there is a little bit of inconsistency implementing those because we have different options for external catheters, and we do have that daily assessment that we actually have to chart it every shift, I believe. Yeah, twice a day. It's not under that name, but it's pretty much all the options that um are available for you to pick of why the patient has or needs a catheter. It's pretty much within that acronym. And there is already in place a nurse-driven protocol to remove the catheter if appropriate. So some of the key strategies also used on the from the research and articles are primarily based on enhanced communication between interdisciplinary team, a lots of leadership involvement, collaboration, real-time data monitoring, audits, feedback, and also ongoing training and education and prevention bundles. Okay. And the most fitting intervention. So something I noticed um in this project is that most of the studies or quality improvement projects that um implemented different interventions for the reduction of CODIs uh was that it's not a single intervention. It was usually like different type of interventions. A lot of them were a mix of evidence-based practice with maybe like change in culture or like behavioral change to help implement the evidence-based practice. But since our unit has already those evidence-based practice tools or interventions available for nurses, I think the main focus will be to kind of just help with the implementation of the evidence based practices. So the most fitting, it's one in like it's like all in one kind of. Um, so the implementation will be pretty much focused on communication during the morning huddles, sharing the report of patients with catheters, the duration that the patient has had the catheter, and the barriers that for removal. And if there is any gaps, that time will be used to deliver real-time feedback, spot on education, and empowerment for nurses to utilize the nurse-driven protocol for catheter removal. And all these are pretty much supported by most of these not most of the um articles, but all these articles, but most of the articles I included at the end are usually like kind of cross-reference the same concept of communication and interdisciplinary team collaboration. For the implementation in nursing practice, I will track the percentage of catheters removed within the 24-hour post-op window, and I will present the data using a histogram. We will also collect additional information on cases where catheters remain longer than 24 hours, including whether the Houdini tool or acronym was applied and what barriers contributed to the delay of the removal. And our measurable goal is going to remain at 30% increase in timely catheter removals within 1 month after implementation of these strategies. And most of these data will be just collected from Epic or the electric medical record. Anything else I need, usually our CNS, it's pretty good at help being a great resource and having access to all that type of data. Finally, for steps for implementation of approval, the next steps will be just acquiring, presenting the quality improvement plan to the nursing leadership, and then getting a certification through the Quality Academy, which is just part of the proposal plan. If you already have one, of course, you don't have to do it again, and they usually renew yearly. Then we will be recruiting a team, the team members, which will be likely the CNS, Epic super users, and some of the members of that coordinating council. And we'll be defining roles, expectations, and how the data that's gonna be extracted and all that. We will also assign data analysis responsibilities for weekly reviews and establish a strong feedback loop so the team can make timely adjustments based on the PDSA cycle. And this ongoing communication will ensure accountability and continuous improvement throughout the project. These are my references. Thank you so much for listening, and please, you can speed up if you want to.